WHQR Public Media, this is The Newsroom. I'm Camille Mojica. Thanks for joining us. On today's show, highlights from our most recent Cape Fear Conversations event. This year, we're focusing all our quarterly conversations on the focus areas of the new Hanover Community Endowment. They include education, community safety, development, and finally, today's topic, health and social equity. Our panelists are experts who all work in the healthcare field in some capacity. Jason Black with the Coastal Horizon Center, Kevin Briggs at Novant Health, Dr. Umar Bowers with Dawson Med and Dawson Med Urgent Care, Haley Sink at Trillium, and the Health Equity Network Officer with the endowment, Lee Quarles. In another segment, we spoke to Fawn Rhodes at the county's Department of Health and Human Services to address a couple things we didn't get to in our panel. We started the panel off with Lee, asking her to explain the endowment and what it means when it says health and social equity.
So for those who don't know, the endowment was formed in 2020 from the sale of New Hanover Regional. And with the proceeds from that funds, it created the endowment for community benefit. We have 4 pillars. They are community safety, community development, education, and what we're here to talk about today, which is social and health equity. When we talk about health equity, what we mean is that everyone has a fair and just opportunity to be as healthy as possible. And we have several strategies which we look at to employ that, but really it's through our partnership with the organization people here at this table and the community-based organizations who are doing the work.
Great. Now, when we say the word access, it's a little bit of a vague and nebulous term. So this is a broad question for everybody on the panel. Whoever would like to start, feel free. But what do we mean when we say access to healthcare?
I don't mind taking that one.
That's Dr. Umar Bowers, the medical director of Dawson Med and Dawson Med Urgent Care. He was recently in Boston for a National Health Equity Summit.
And I think it's a term that we use often, and I think there's 2 sides of it, right? There's access, meaning the opportunity to receive care is where you can get to it, right? And that also means the supply-demand is not mismatched adversely. So there are enough clinicians, whether it's nurse practitioners, physicians, therapists, whatever the case may be, to take care of the number of people that need care. So there's sometimes supply-demand mismatches. But also within access is a subcategory of utilization, right? And what's the utilization rate relative to the access? But it's just making sure that people have access and the ability to receive care, whether it's a payer source that helps them receive care, or whether it's a number of clinicians in their community that can deliver that care to them, is a pretty good start to looking at access.
What is preventing our region, like some things in particular, from achieving healthy outcomes for all residents here in our area?
The ability to get to the care is difficult.
That's Jason Black, the Adult Residential Community Treatment, or ARCTS, program director at Coastal Horizons. His audio was echoey at first, but we fixed it shortly after.
Time frames, bus routes, those kind of things.
Next is Haley Sink, the director of health equity at Trillium.
I think in looking at it, I'll definitely agree, Jason. From a numbers perspective, out of 100 counties in North Carolina, New Hanover is 15 ranked, and with one being the best, out of having healthy outcomes. So saying quality of life, average life expectancy, and not having a substantial number of risk factors for health. And that's continued to rise over the last, 5, 6, 7 years. But on the opposite side of that, the data shows for all of what we call social determinants of health, or social drivers of health, or what the state now calls, and I appreciate this one, unmet health-related resource needs. If you look at New Hanover County for things like access to food, access to transportation, living near a grocery store, all these things that we know really, really matter to health, they're below the state average in every area. So we know the need is there, but it's, in my opinion, I think very much outshined by the wealth and the good health that's on display for the county and showing up in these good ways on lists, not at the bottom of the list, but at the top of the list, but then leaving those folks that are of greatest need behind.
I'm glad you mentioned health outcomes, because every year that report comes out, and of the 100 counties in the state, each county is ranked annually. So the question is, what do we do in New Hanover to go from 15 to top 10, right? And social drivers of health, right? We used to use the term social determinants of health, but social drivers of health are going to be how we impact that, because there's great data, really robust data that says your zip code is a greater predictor of your longevity of life and your health outcome than your genetic code. So understanding that 15 is actually not bad, right? But we can do better.
Up next is Kevin Briggs, Senior Director of Laboratory and Respiratory Care Services with Novant Health.
I think another part of that also is really making sure that even with all of the data, and we do have some really robust data, that is so important to listen and to have sessions where we're making sure that we're hearing the voice of everyone that we serve. So really making sure that we're engaging in every single part of our community.
Now, bear with me here. This is a little bit of context for everybody. But the recommendations for strengthening behavioral health care workforce 2024 plan from North Carolina Department's Health and Human Services shows that 94 out of 100 counties in North Carolina are designated as health professional shortage areas in the area of behavioral health. New Hanover County has a high need for behavioral health professionals as of 2023 data from the state. So how do we build up local behavioral health infrastructure to relieve some of that demand?
Everyone looks at me. So I think that one of the things that we've had to do specifically in New Hanover County is look at cost of living increases. New Hanover County has exponentially increased post-pandemic, and we can still say post-pandemic. It's been difficult. We've had to do an entire across-the-board evaluation of salary ranges and cost of living, and we've looked at some data in regards to New Hanover County specifically, and economically, 50% of our population of people that are working in New Hanover County are living outside of the county. So we've got to figure out how to effectively compensate behavioral health workers while still being able to provide services to those who are most in need.
Well, we're glad the bridge is open. I just wanted to give a shout out to the endowment and your colleagues, Lee, because I think there's been a good number of resources looking at this, and the chamber here in town is doing a lot of work for pipeline and workforce development, and again, a multi-stakeholder approach. The North Carolina Health Talent Alliance out of essentially Raleigh and AHEC is working with some players here in town, and we're really doing the deep dives from an organizational and institutional standpoint of where are the needs. Is it nurses? Is it therapists? Is it psychiatrists? And kind of drilling down to specifically where are the needs and how do we recruit and retain to fill those needs. But statewide and even beyond that, we are in an arms race for talent, right? So it's not just a factor of this area. The arms race for talent is on and is going to stay on for a while. So we want to be a winning community that can recruit and retain.
Yeah, thinking about that, and, we have our opportunities today, but then we have to look at this from, 5, 10, even further out. So really making sure that we're working with all of our pipeline entries to include our academic environments and our youngsters who are coming along, making healthcare something that's attractive to them, a place that they want to work and serve.
For touching on the opioid epidemic, Jason, I want to start with you. Can you tell us a bit about the scope of the epidemic in our community and what you're seeing and hearing from clients about opportunities for treatment and long-term care here?
So we have been, I think, blessed with a county and a city that are concentrated on the opioid epidemic before post-overdose response teams became a huge thing. Before even the suit of of Purdue Pharma and those kind of things, we were already on the ground with the quick response team at Coastal Horizons, and now we've expanded into Pender County as well. But there is a huge amount of opiates coming through the New Hanover County area. And what we are seeing is a large access to treatment options and long-term successes in getting people connected. We did a report for the city last month, and with the quick response team, which is Coastal Horizons overdose response team, we have seen a 1% fatality rate after somebody is connected to treatment. That is not good enough for the team that I operate. They are heartbroken by that 1%, but to think that 99% of the people that we are connecting to treatment are alive and able to thrive is huge. The availability of more services, and you see more resources within New Hanover County expanding to provide those things, to provide MAT is medication-assisted treatment, methadone or Suboxone daily dispensing, also office-based opioid treatment, which includes Sublocade or Suboxone that somebody gets on an outpatient prescription. But the availability of providers who are willing to work with that population, where a decade ago they were scared to take that liability, has increased as well. So there's a lot of hope for the amount of impact that we have in the community with these partnerships, getting people around the table to say, we're willing to accept these people that have experienced this and move in a positive direction.
I think I'd be remiss if I didn't call out the fact that, number one, thank you to the Coastal Horizons team for the good work that you're doing. But I think there is, amen to that, right? There is also an opportunity to engage in more minorities receiving this treatment and care, because in our office at Dawson Med, we're primarily primary care. We also do urgent care, but we've also integrated some behavioral health. And the overwhelming majority of folks that come to our office for treatment of substance abuse services do not look like me. And so whether it's stigma, whether it's education, whether it's access, whatever the case may be, I would love for us to continue extending access to those who may not necessarily be your traditional patients in that realm. And that's, again, regional. This isn't Coastal Horizons, because what Jason just described is phenomenal. But just calling out, as President Maxwell from NAACP walked in and joined us, good afternoon to you, ma'am. Calling out, we want to do everything we can to make sure everyone is aware of treatment options and takes advantage of them if it's the right time for them, not just one segment of the population. I don't know about others in the audience. I've lost someone to complications in my family here in Wilmington related to opioid use disorder, and she was 25 years old. And so we carry her legacy and her memory with us every single day when we extend treatment options to everyone. But I just feel like there's opportunities, I'm not sure if you all see this as well, of broadening that tent.
I think that's a great point, in that we see a higher level of white people seeking treatment, whereas the minority populations, people of color, are not accessing treatment. And you'll actually see from the data that the effects, the long-term effects of addiction, are more prevalent in the minority populations, according to the data, than in the majority populations. So as far as health equity goes, it's essential that we're able to access. And one of the things that the post-overdose response teams focus on is relationship and being able to be in those populations. So we have had the opportunity to take our homeless street outreach teams and our quick response team and combine those teams in their outreach potential, so that there is a warm handoff between one and the other. Being in the communities and finding a way to continually be present in the communities that are most effective are huge. If you look at the heat map, so New Hanover County has a heat map for where EMS, police, sheriff's department respond to overdoses. If you look at the heat maps, we know that the heat maps are a good indicator of where we need to be, but there are a lot of stigmatized populations that are not calling EMS, the Sheriff's Department, or Wilmington PD in order to access overdose response. So one of the things that the quick response team is doing is engaging in those communities to say, we've got Narcan, it's available. Here are the places that it's available. One of the beautiful partnerships that we've had is with the church community within the greater Wilmington area, because there are churches that are like, we are willing to put a Narcan box up in our church. Black churches, white churches, a whole gamut, and they're saying, we want the training, so help us to be educated on what this looks like, and then we want to be the source. We want to be the relationship, so that if they have it there, they know that somebody's going to come, and if they want to, can engage with whoever the leadership of that faith organization is, in order to say, where do I get more of this, or how do I get more treatment? And I think that's essential. I think that the populations that are afraid, genuinely afraid to access treatment, are the populations that we need to be engaging with on a regular basis. And I think that community collaboration is what's going to help with that. The grouping of the people that are here, so that we can say, what neighborhoods, areas, zip codes are we missing? Who are the people that are hiding, and how do we best present ourselves, whether it's mobile clinics or homeless outreach teams or new Michael Jordan family clinics? How do we get in there so that we can have as many health workers establishing relationships and positions of trust to get people to come to us?
And I'll just add, I think that's just such a great call out, Dr. Bowers, and so appreciate all Coastal Horizons is doing as boots on the ground in our communities. But I think that's such a perfect example of how, centuries of racist systems and just mistrust in communities directly affects accessing care, because you're not going to call the police if you are in a zip code that has just, again, centuries of trauma with that relationship. So how do you get help? And then looking at, where we're positioned with the state with the $847, $million investment in behavioral health, and that includes certainly substance use disorders and intellectual and developmental disabilities and a gamut of services. But how do we leverage and value folks with lived experience, whether it be peer support specialists, whether it be community health workers, that look like the people they're serving, that are from the zip code they're serving, and have this tremendous experience in this recovery journey that they are now ready to share to help someone else, and whether it's their personal experience or someone that they lost, a loved one they cared for and loved, and so many of us in this community are affected by this opioid epidemic and crisis. How do we lift those folks up and value them, pay them a living wage, a wage where they can be here in this community and help to be part of that solution?
I also want to say that I think this is a really good example of how, I love data, but data doesn't always tell the full picture, right? I think if we go on traditional data, we think that only certain populations are affected by this pandemic and their epidemic, and there are people that are missing. And they're missing for a reason, for all the things that we were talking about. And so I think, from my position and what I do, data is really important, but it's really important to understand the context around that data and what isn't showing up.
Medicaid expansion was really important to making sure that more North Carolinians were covered by Medicaid. However, data from the state, 2021 data, shows that nearly a third of Hispanic and Latino North Carolinians are not covered by insurance whatsoever. So how do we reach this population?
Well, whoever has that answer, we'll be on a much bigger stage next week. But I'll speak to at least what we're looking to do. We actually just hired a physician assistant. She started a couple of months ago, of Venezuelan descent, Spanish speaking. Really excited about that, because I think there's robust data that says the matching, right, of the patient and the clinician that's taking care of them is something that impacts their ability to initially seek care. Now, once they come in your doors, you've got to win them, right, and keep them. But we are at least trying to make inroads into that very valuable community or segment of our community by having a clinician that speaks Spanish full-time. We've got a medical assistant who also is a UNCW student, which we're really proud of, and she speaks Spanish full-time. So all of our organizations have interpreter services, but I think there's a difference with having a warm body in the building, right? You can always get on the other end of that cold phone and, kind of do it with your phone, the Google Translate. Anyone else doing Google Translate communicating? But what we're looking to do is make sure that the community knows there's someone in the building that looks like them and has some shared experiences as them.
I agree. I think one of the things that we focus on at Novant Health is making sure that our care is truly culturally and linguistically appropriate. And the only way to do that is to make sure that our workforce is also, truly reflecting the community. And then there's the traditional sense of healthcare, and then there's the opportunity for us to be more and more innovative along the way. One of the initiatives that I'm really involved in is a simple thing called the Barbershop Initiative. And it's really a place where we can begin having those real conversations, opening the doors so that we can begin building those essentials to access, and that is trust, that is understanding. So we go into the barbershops, meeting individuals where they are, primarily black, traditionally black barbershops and Hispanic or Latino shops. And taking our individuals who can connect from a language standpoint as well as reflecting that community overall. So that just opens the doors. And then from there, we're able to understand more about the barriers and the access points that are needed, and then share those resources. To Dr. Bauer's point, it's so important for us to be collaborative. We realize that as you look across the table and you look at the organizations that are represented here today, it takes this group and more working together, including all of you, to make sure that we're taking care of our community in the way that it needs to be taken care of.
This has to do with the population covered by North Carolina's Olmstead Plan. So basically that says that North Carolinians with intellectual developmental disabilities deserve to live in communities that they belong to. They should not have to be institutionalized or go to a nursing home to receive basic care that they need. So, Haley, let's start with you. What are some ways that we can create communities where people with intellectual and developmental disabilities can live independently in their own community?
Absolutely. That is something we're very, very passionate about at Trillium Health Resources. And we are a health plan for Medicaid, but we serve folks with the highest need in terms of mental health diagnosis or behavioral health concerns, and then also traumatic brain injury and intellectual and developmental disabilities. So a broad population there. But thank you, Cami, for that description of Olmstead. And yes, that was a 1999 Supreme Court ruling that, I want to make sure I quote this correctly, and for the ADA, which is the Americans with Disabilities Act, it was found that unjustified segregation of individuals with disabilities constitutes discrimination. So that was the basis there. But the interesting thing, and I love history to be able to bring understanding and for me, truth to where we have been and where we are going. But Lois Curtis was the name of the lady that really brought this case to light in Georgia. She was the lead plaintiff, and she was an African-American woman, an amazing self-taught visual artist. She passed away about 2 years ago now. And she said, she came in at 11 years old and was voluntarily admitted to a state psychiatric hospital, and then after treatment just continued to stay there. And why? And there were no options. And so her and a friend really advocated from the inside out to bring this case to light and to live in their community, and which she did successfully with that ruling. So here in North Carolina, the latest case of that has been the Samantha R. case, which you may have heard about even more recently. There was just a settlement with Disability Rights North Carolina and the state in April, and that case was over Samantha Rooney, who is a young lady with intellectual developmental disability and also physical disability, and her family could not get the care they needed for her to reside in the home with them. And they, really just were unable to care for her, and they wanted her to stay in the home. She wanted to stay in her home and in her community, but the resources just weren't there. So again, this has turned into a settlement that is going to be a good thing. It also covers our foster care population, which we know, about 30% of our kiddos are children of color, but 50% ended up being placed, I know Ms. Maxwell has spoken to this as well, in these psychiatric residential treatment facilities. And we know how important it is for our children to be in communities with folks that look like them and are, of their culture and can be just fully integrated in community wherever possible. So we've got about 17,800 folks in the state, 345 here in New Hanover County that are on what is called an innovations waiver wait list. And that is all for children or adults that have intellectual developmental disabilities and need care to live in the place of their choice, to live in the least restrictive environment that's appropriate for them. That is a lot of people, and I meet folks all the time in our communities talking to them about what the needs are, and they'll tell me, my kid's been on the wait list for 11 years, 8 months. My kid's been on the wait list for 9 years. We've heard 10 is usually when we get off, like, please, do you have any information? It's heartbreaking to say the very least. And here, certainly in New Hanover County, we have an aging population. We have retirees moving here with children, adult children now, that have disabilities. And for me, my oldest sister, Megan, very much in that situation with my parents. And she's 36 and has complex needs and still is able to live at home thanks to finally getting off that innovations waiver wait list, right? So long story short, but it's very complex, I feel like, to understand, but those wait list slots come out of Raleigh. So advocating for those, helping folks understand, because if you haven't lived that day in and day out, you really don't know the need and how important those services are. And the other thing that is new that can help in the interim, and is the first time the state has really been able to provide something for folks while they're on the wait list for these services, is called 1915I, back to, access to care. Sometimes I think just having names that might make just a little bit more sense to folks could also help with that. But 1915I is now something that you can request if you're on the wait list to get services, to get respite care, to get supported employment access so you can live if you have a disability. We know about 80% of folks with intellectual and developmental disabilities are not employed but have so much to offer the workforce and their communities. So that's another service that's now available. So sorry, Kimmy, that was a very long answer, but something I feel very passionate about.
No, that's why I asked.
Your subject matter expertise covered the four of us. So,
I had to Google it, if I'm being honest. So.
I'll yield. Continue, please.
For a super, super broad but important question, how do we deliver health care, both physical and mental, to more rural areas?
I can take a stab? Okay. I think the first thing we have to think about is intentionality. One of the other hats I wear is for one of the Medicaid plans here in the state on their QI committee. And so we know, to the extent that there's heat maps, there's also cold maps. Yep. Right? There are areas that have been deserts for healthcare providers for decades on end, and actually those trends are growing, right? As places like this, a wonderful city on a gorgeous day, right? How about everyone that spent time out of their day to come join us today on such a beautiful day? Thank you all for being here with us. With COVID, right, to kind of bring that back to the fore, a lot of folks were working remotely, and it just changed their aperture of where they could live and work. And so they just viewed it from a different lens. So we've seen actually a greater migration to large urban areas. And so therefore the individuals who live in these rural that were already deserts are even more deserted now. Yep. Right? So there's been innovative approaches with mobile care. I think virtual health will probably be the greatest equalizer from a disparity standpoint. Exactly right. So I'll toss it. But so it's a problem that the North Carolina Medical Society has been working on for decades on end. And you can incentivize coming out of, I can only speak from the physician's perspective, you can incentivize someone coming out of med school or their residency training, give them loaner payment. But if that really worked, then we wouldn't have the incentives. We wouldn't have the problem in spite of the incentives. Right. So we've incentivized folks to go to these rural areas and live there for so many years. It just hasn't been successful. Yeah. Because after a certain time, either the loan repayment is no longer as attractive as it was, either their spouse may not, right, be as enamored with the place as they are, or whether it's a child care and education decision that they make subsequent to their original agreement. So that's been a challenge. But I think virtual care and the delivery of services thereof can be at least a big dent in that.
I can't say a lot from my role here at New Hanover County, right? But I moved here from Kansas City, working with a foundation that funded in Missouri and Kansas. And Kansas is a really good example of some of the innovations that are going through to address rural health needs. We're dealing with a sale of a hospital here. Rural areas are dealing with complete closures, right? So what they're doing in terms of access to care, people have to drive, Kansas is a very different area, but 4 hours to get care. So that's where we've seen a lot of the innovation. I think what actually works is that community development piece. So much of health happens outside of the clinical setting, but you aren't going to be able to just pay people to come and stay. People have to see themselves there. They have to be able to make a community. And so there have been some really great efforts in those states where the community development, redevelopment piece is coming to play, because the rural areas are exactly what we're seeing here. Aging populations, people are moving away. Younger folks want to be in the urban areas. That's a great thing for us here in New Hanover County, right? We don't have those same experiences. But digital equity is a real piece as well. That the pandemic really highlighted that there are so many areas that, and addressed it in many ways, right? We don't have the same lack of access to broadband internet that we did before. But it really does come from telehealth and those connections to our urban health centers, but also that community development aspect as well.
I'll lean into that a little bit. Dealing with a lot of the homeless population in Wilmington, as my team does, I love the idea of virtual. We are still restricted for people that don't have access to virtual. If somebody does not have a cell phone, and we can work to get you a cell phone, but the federal government provides you 2, and that's it, right? So if you lose them, if they get stolen, if something happens, you're out of luck. And as far as I understand, you can't do a virtual appointment over a payphone or a flip phone or whatever else. You have to have that visual access. So one of the things in this county specifically that we have been really struggling with is access to transportation. Whether it is opening bus lines or giving more access to bus tickets or having a county-based Uber contract or Lyft, let's not specify one versus the other. But being able to say, hey, we understand that you don't have access to a cell phone. Because think about it, if somebody is in a socioeconomic status where one human in the household has access to a cell phone and that human isn't there between 9 and 5, that person is restricted. They can't access that. So I'm not being challenging at all. I think virtual access in those rural areas is essential, both with broadband and the availability of physicians and therapists to be able to provide that. We've seen that in the pandemic. Those avenues and those doors have opened up. But for my team specifically, being able to get to someone, put them in a vehicle, and get them to the center, and Medicaid transportation does that, but you've got to get them set up. That's not urgent. Mobile crisis does that, but again, that's not a recurring service. So one of those things for the people that are marginalized and that are socioeconomically unable to provide themselves a cell phone or a car or a bus ticket, those are the people that we're seeing that their mental health care and physical health care needs aren't getting met because that infrastructure isn't there. And the more rural you get, the harder it is, right? So you leave New Hanover County and you go to Brunswick and Pender, which are the two of the largest counties surrounding one of the tiniest. It gets even worse. The Pender County folks don't have transportation, and so they are reliant on Medicaid transportation to get them to all of their appointments and those kind of things.
And I think that's where mobile health care is really important as well, and place-based care. Looking at non-traditional settings, you don't have to have a cell phone. You can go to a community-based organization that might not even be a clinical space, and they're able to provide those options. And so we're seeing a lot of great solutions. It's not perfect, right? Ideally, our hospitals would still be open, and we would have clinicians that want to go work in that space. But again, so much of health happens outside of our clinical space. And it's really looking at who else we're partnering with and those collaborations, again, to make sure people have access.
I will call out Novant's mobile unit has been huge, and we are a part of the collaborative. There is a mobile collaborative in New Hanover County of all of the people that have buses and trailers and community-based workers that are meeting on a monthly basis to say, where can we be? Where is the most need? And again, the more people that can sit at the table and say, we need you to show up in our community, the better. But that having enough having enough people with mobile trailers to provide services has had a huge impact in the community in general. So that, yeah.
And I appreciate the pushback, and I think our microphone is an example of access and equity. so this is just for demonstration purposes and collaboration, right? But that's very fair pushback on the telehealth issue. There's now, right, questions, will this digital divide be the next form of disparities, right? So it's very, very fair to call that out. But again, just opportunities for us to really have the discussion about how do we then mitigate that. Right?
Yeah, and I think it's fair. What we've heard is that it's going to take a diverse approach. It won't be one single solution. It'll be a combination of the solutions. So, not only the virtual aspect, but and even the community cruisers that we have that are placed here in the coast on the Navant Health side, we recognize that that's wonderful for screenings and our primary care, but even going a step further to look at some of those diagnostics like our mobile mammography unit that goes out to the communities. And the partnerships, again, are so key. We talk about our faith, health network, as well as, the barbershops and all of these maybe unconventional ways of meeting people on the topic of healthcare.
And I'll just add to that, Trillium really, and what drew me to the organization is just so rooted in partnership and innovation and serves rural very well. So we previously had 28 counties in North Carolina, pretty much all rural or coastal communities, and now have grown to 46 counties. And mobile clinics, we have 7, almost going on 8, another one that's going to be launched. And those really are rooted in provider partnerships with Coastal Horizons, with RHA, with Port, with others across the coastline to bring that access. I mean, some of our communities, in thinking about Outer Banks, are truly only accessible by boat. And what a challenge that creates for just getting physical and mental and behavioral health care to folks. And the other thing, I think back to your question, Cami, with our Hispanic and Latinx population and the tremendous amount of migrant farm workers that we have here in North Carolina throughout this region too, and knowing that a 9-to-5 doctor's visit isn't going to work. There's fear, do we have the right papers? Do we have, what does that look like? But then also, if it's a really good day harvesting, you're not done with work until 8 or 9 p.m. and you don't have access to truly even just to hop in the truck and get to where you need to go. So having those clinics where they can really work for the community, work for the people in the community to creatively and non-traditionally meet those needs. And then one just kind of quick story on partnership and faith-based. To Mr. Briggs' point, there's an amazing Reverend Joyner in Edgecombe County who's one of our Healthy Opportunity Pilots partners. Truly a community-grown effort there in Canita, and just an incredible leader for his community, but saw the need, got together with folks and said, we are burying, in this case, he said, my church, since I've moved here, and he moved from out of state, has buried entirely too many young black men. And he said, what are we going to do? And so they got together and they've created now, which is a 50-acre community farm fully owned by the community, but the kids and the elders in the community all come together to be able to have and to feed their community with truly. And now that need has been met through this organization, through the church. They have all kinds of things going on. Like the 5-year-olds make the honey from the beehives and gave me the most amazing honey when I was there to visit. So highly recommend swinging by if you're up that way. There's just something for everyone and that commitment. But thinking outside of the box, he knew they needed a psychologist in that community, and the clients were there, the patients were there. But how do you get someone to come to that community? And he said, you know what? The church has a space right here, rent-free, if you'll come and practice with us, and I'll get the folks here. You'll be able to bill and get paid. So just thinking, again, those non-traditional ways, and just a way that in one of the most rural communities I've been to, seeing that just come to life and work so beautifully.
I will demonstrate my commitment to all North Carolinians. I'm willing to volunteer at the Outer Banks. Anytime.
It'd be my first call.
Absolutely. Friday, Saturday, and Sunday. Sign me up.
We appreciate that. Yeah. So this is our last question for the first half of today's panel. Now, we know that money isn't everything, right? It certainly helps with making systematic shifts, and we do know that there are things that we can do with the right amount of funds right now. But what would truly transformational change look like in the field of health equity?
I'm a data wonk, so I've spent a lot of time on the Hill and in Raleigh. So I can tell you that the United States spends more for health care than any other developed nation, and we have less than ideal outcomes. So clearly throwing money at the problem is not the issue, right? I don't want to bore you with the data and statistics, but the reality is most care does happen outside of our clinic walls, right? No matter if we're kind of going to them. So I think there has to be an approach that is an access approach, a collaborative approach, a resource-rich approach, but at the same time, there also has to be an effort to develop relationships with patients to also impact behavioral changes as well. And this is not a paternalistic approach, but you can have Medicaid expansion, right? So the numbers we projected were about 600,000 North Carolinians would then have access to care that did not have access to care. But the question still is, then what, right? So there's a lot of money involved in that calculation. The General Assembly, right, was on the fence for a while, and you know, no matter where you stand on the political spectrum, I respect it. But I think Governor Cooper's administration and Cody Kinsley did a great job of working with the GA to kind of get that done. But now that that is in play, and now that those federal dollars will now reach our hospitals in those rural areas that are struggling, what do we do about it? Are we going to utilize that everyone that now has Medicaid that didn't before is going to get a mammogram or a colonoscopy or cervical cancer screening or work on tobacco cessation or all the things that we know are impacting health? Because I'm excited for Medicaid expansion, but I know that's just the first step. We have to do something with it.
That was good. We do appreciate Medicaid expansion. The biggest thing that I think I would focus on is community and collaboration. I think that being in someone's community makes you a face that somebody sees, right? So having people that are not necessarily doctors would be great, but y'all are busy. But being in the communities, having community with somebody, because there are plenty of people that have come across our desks at Coastal specifically that we said, have you applied for Medicaid? And they went, why would I do that? Because you qualify now. And they didn't know. And so I think that the collaboration and the community, having somebody in the community who educates on what the effective things are, if Horizons Health or Dawson Family Medicine or whatever are there and are a safe space for people to come where there is a warm body who speaks their language or a warm body who knows their culture, nobody's going to know that unless somebody within their community, whether it's a faith-based leader or a teacher or somebody else, says, hey, this is a safe place to go. I also think that the collaboration, me being able to go, I know the doctor here, they'll take care of you. Or being able to culturally and directly and go, hey, this isn't a service that we provide. Who are the people we can hand them off to, and being able to physically take them there or hand them off to that provider for the enhanced service that we don't necessarily have the capacity for. Having that community and those relationships is essential, especially on a directorial or an officer level, because we can make phone calls. But if we get our people in the communities so that they can establish those relationships, then they can make the recommendations. I know Mary's the medical assistant at X clinic. Let's go talk to Mary. Those relationships are essential. And yes, Medicaid expansion was great. And having people who can now qualify for care is great. The next step is how do we convince them in a stigmatized, racially divided location to trust the people that are accepting that care and to know that they will be treated the same way. I think that Medicaid comes with its own stigma, right? You're in a Medicaid clinic, that stigma needs to go away. Medicaid people need to be treated the exact same way that somebody with any other insurance is, and that takes education and it takes commitment from the community, the medical community that are here.
Absolutely, to both of those statements. And I think just it's always interesting to me, if you have never called around to ask, a provider, do you take Medicaid? I mean, just do it sometime. And I know Katori on my team is amazing and has recently done this as just a little a self, just a project to inform us too. And it's just about the same as it was how many years ago, forever. And I think that's one thing. And then you're asking folks that are Medicaid recipients that exactly deserve the exact same care, high quality, superior care as anybody else, to navigate this system that wasn't designed for anyone to navigate, no matter what else you have going on. But if you're so very focused on just, I've got to get to work, I need to find a way to feed my family, feed myself, and now spend hours on the phone trying to access care, access an appointment, how difficult that is. And then if you have tried to get on Medicaid before and had to go to, our wonderful partners at DSS, Department of Social Services, that are doing everything they can, but it's just a lengthy process. So if that's the last experience you had, and it took hours and time and energy and trying to get all the documents, and usually it's going to come back to you with something that was missing or not quite correct, and now you got to go do it all again, and maybe you'll get it, but is it really worth just continuing to keep putting up that fight? And it's just so disheartening. But I think to your point of depending on what your diagnosis is, you might also be on Medicaid. And my family does not live here close by, but in the state of North Carolina, and where my sister, who has a disability and is on Medicaid, receives care. You check in, and if you're on Medicaid, you go to the left, and if you're not, you go to the right, and it looks completely different. The mahogany cherry walls are this way, and then just like bare minimum is over that way. And I mean, I just think even those visuals, that it just is so stark to me and gives me chills every time I mention that, but it's still like that all these years later.
And I guess maybe the $1 billion elephant in the room, what does that look like for us? I think, we there are funding sources, right? And those funding sources are very restricted. And so it is our job to be paying attention to where are these gaps, what isn't being funded, narrative change, which is really what we're talking about here with understanding Medicaid. And with Medicaid expansion, that means that private providers, can take Medicaid too. There's a whole education and getting them on board with what that means, because we have so many misconceptions about what it means to be a Medicaid patient, number one, who qualifies. Not always who you think they are. We don't know what we don't know, though. And so oftentimes there aren't funding streams to cover these gaps that are things that we want, these broad policy changes that increase access. And so that's why we're here, to sit and listen to our partners who are doing the work and saying, we really need to do this, but we don't have a way to fund it, or we don't have a way to fund it at an adequate level. And we see that a lot. And so we're new, and we're here, and we're learning, but that is what philanthropic dollars, from my perspective, are here to do.
And I would just be very remiss to say, so I did live in New Hanover County for several years, came here for school, and our nonprofits, our community-based organizations and faith-based organizations, if you've heard us talk about so much and how that collaboration is key, they are the ones who have been just meeting the need day in and day out because it's the right thing to do, and they're just trying to make a difference. And I think in whatever way we can lift those organizations up that are essentially having to be the Band-Aid for our society, for our communities, while we try to dismantle these systems that have been in place for centuries. We know that's going to take a lot of money and a lot of time and a lot of energy, but we've got to take care of our people, and most often it's those community-based organizations and faith-based folks that are getting it done for us.
This is a very this is a good question. So it's what role could eliminating medical debt play in enhancing the health of citizens in New Hanover County? Go for it.
I think economic factors are one of the biggest causes of stress and poor health, and those efforts to reduce medical debt, it makes it that much easier to, number one, breathe, you stabilize. It's hugely impactful, right? If you're not worried about creditors coming after you for seeking health care, a lot changes.
I love that. There is definitely trepidation sometimes for accessing care for fear of medical debt. Mm-hmm. The paradox is often if we delay care, delay diagnosis, right, that debt gets higher. But maybe from a different lens, I also think med school debt. And I know there may be, may not be a huge audience with an appetite to hear about med school debt, but the reason why it's relevant is because I'm admittedly biased as a primary care internist, but the decision when you have that inflection point in med school, right, about which specialty you choose, if primary care continues to be underappreciated and under-resourced, you'll have fewer primary care physicians in your area. So subspecialists are always needed and valued, but I believe that primary care is the foundation, or should be the foundation of our health system. But I don't feel like we're going to solve the med school debt. But I love the question about medical debt. I think that's a very, very great question, whoever asked that.
North Carolina, I so appreciate that question. North Carolina Center for Justice has done a great deal of qualitative research, for lack of a better word, just getting folks' stories. And I mean, the amount of stories where someone went in with a sprained ankle because they couldn't go to work and needed a note, and that was $12,000. And then something else happened, and now they're in $50,000 in medical debt. And what that does to you, I mean, your whole life, every aspect of your life, when you were already, just trying to get through each day. So it's just so many examples of how one accident just can snowball, and gosh, what that does to your mental health, not let alone just getting treatment for physical health is incredible. So that's a very important question. Mm-hmm.
Well, we also think about the fear of going to the doctor, whether you're insured or not. Depending on what your copay or your deductible is, it prevents you. But the fact that mental health care is still stigmatized as something that is unnecessary. Mm-hmm. And so if you are underinsured or uninsured and you are dealing with mental health symptoms, whether they're simple or complex from a cultural perspective, if I'm worried about medical debt in regards to my physical health, I'm definitely not going to go for my mental health, and it snowballs. So I think that's huge. We still have to find the funding source.
I know we at Novant Health are sensitive to this topic, and one of the things that we have is a financial assistance policy, and that is in place for individuals who are at 300% of the poverty level, that they could potentially receive 100% write-off for those services. What that kind of means is, a family of four with an income of about $93,000, that's where this really comes to play. So a lot more work that we have to do in this space, but just trying our best to help alleviate and make a difference where we can.
Next question is, how do we address low wages for healthcare aides and direct caregivers, especially with our aging population here in New Hanover County? Mm-hmm.
I can kick that off just from the perspective of saying with, innovations waiver for folks with disabilities, or whether it is our aging population, we're getting the funds in place to be able to provide services for individuals to live in the setting of their choice, whether that be home, community. But if we don't have the workforce to make that happen, that we're just waiting for the other shoe to drop. So that's definitely of concern.
And think from a cautionary tale, San Francisco, and this is not to say anything ill of San Francisco, but we saw the influx of just tech dollars and this enormous surge in everything San Francisco as far as cost of living. So it was so bad that teachers and police officers couldn't afford to live in the cities and the neighborhoods where they served and worked. And I don't think that we're necessarily there yet, but we should use that as a cautionary tale of just making sure there is always, as the cost of living, in my opinion, goes up, which is not a bad thing. I don't think that's a bad thing at all. We live in an attractive part of North Carolina. I'm very happy to be here. But we need to make sure there is always a balance, and affordable housing and affordable living has to be part of that equation, or else it will impact us, each of us, from an educational standpoint. If you've got children, right, what's the quality of teachers in their school? And we can just kind of follow that frame of thought all the way through, that you may be living in a wonderful neighborhood, maybe you live in a neighborhood that's, middle of the road, whatever the case may be, somehow we will be impacted if others in our community can't afford to live here and work here as well.
Next question is, what is the perception of the at-risk community of what they need related to health?
taking not the perception, but what I love about my role at Trillium is we established in January 2024 our first Health Equity Council, and it has all different roles that represent historically marginalized populations, as the state term goes, but making sure that everyone that needs to be there is there, and constantly evaluating those roles with this council, saying, you know what, I think we're missing this voice or this representation. The caution in that is that's one person's voice at the table, right? And they certainly can't represent an entire community, and that's not a fair expectation. But how do they link us to their community so we can amplify the voices of these at-risk, populations, and hear directly from them? Who knows better what they need and what they're facing to be part of the solution? So what we're doing now, and we're establishing regional health equity councils. Again, we grew to 46 counties. We have 5 regions. So Katori here will be heading that up for our southern region, but we want to stay local. That local voice is so important to being able to solve these problems together. And those councils have, folks that are people with lived experience, people that are family members, people that are providers, and from these community-based and faith-based organizations too. So it really is a very unique way to go about it. And then we're able to take from our clinical team, here's the evidence-based intervention or the best practice thing that we know should work, right? But so often for our at-risk or marginalized communities doesn't work. And instead of coming at it from, we're prescribing this intervention, working with these communities from the beginning to say, what are you truly facing so we can tailor this? Is it a barrier with language? Is it a barrier just simply geography, transportation, just getting those nuances figured out so we aren't saying, oh, they need transportation and putting a whole system together, but then guess what? It doesn't go to the library for community meeting on Tuesday night. It doesn't go to Walmart, where that's the only place we can affordably shop anywhere nearby. So just having our communities be part of the solution from the very beginning.
In the behavioral health or BH space, I think perception is really important, because I think when someone feels like they could be misperceived, it could be potentially fatal. And we just may not have that second chance. And from a substance use disorder standpoint, particularly in minority patients, I can tell a story that shocked me because I wasn't in the clinic. We are right up the road, Dawson Med Urgent Care, just a few blocks up Dawson Street. And there was someone that had an overdose right across the street. And they didn't call 911, right? And they ran across and grabbed some of our team members to come render aid, and of course they called 911, right? But we administered Narcan, we did some of those initial things, but I think in hearing the surrounding, right, people that were there, that none of them decided to call 911, they were just afraid. They were afraid that they would have been perceived as they had contributed in some way, shape, or form, although they didn't, so they were afraid to call 911. But it's also, I'm surprised we're an hour plus into a health equity discussion. We haven't used the term implicit bias yet, right? Because we do, each and every one of us, right, no matter what side we sit on, we have implicit biases. And so sometimes these perceptions that patients feel are fair. So calling them out and just making sure, we have used the term stigma a lot, that we destigmatize all things, including behavioral health disorders, and under that umbrella, substance use disorders. We've got to destigmatize that, especially in marginalized communities.
Now, with the endowment's restrictions to New Hanover County, how does it still play a role in addressing overall regional health care issues?
Yeah, I think that, as a funder, it is our duty to collaborate with other funders in that space. Just because we have parameters about where we can and can't fund, but there's other funders who can fund in those areas. And so we take that pretty seriously. We are one of very many funders in this area. And while historically Southeast North Carolina has had less access to those funds, having an organization like the endowment allows us to serve as a partner in receiving more funds, letting the message get out, making sure that we are talking to folks that we know might have an interest and an ability to fund in those areas and bringing them to the table. So when we talk about collaboration with our partners who are out there doing the work, there's really critical collaboration that happens from the funder space as well.
So could we achieve a number one healthy outcomes ranking in the region with $50 million a year?
Well, I think we're number one in the region. Could we be number one in the state?
Yes.
Is that the question?
Yeah.
All right. How about we toss that question?
We toss it?
Yeah.
I mean, I don't want to say, what's the time frame on that, right? So $50 million a year or more over a sustained period where we're really able to partner, maybe. I mean, I think you look at who's been number one. I think there's 2 counties that fluctuate between 1 and 2. There's a lot of things that exist there that don't exist here. I'm aspirational. I think, yes, we can get there, but it's something that takes time, and it's not just a $50 million a year, right? It's about what resources are available and how we are utilizing them. I think, and bringing some of those resources that maybe exist and making sure we have them here. I think the Sickle Cell Initiative is a great, how many people still travel down I-40 to the county that is number one and has been for a really long time. So what does that look like? I think yes, but I think it's not just about the $50 million a year.
I think we have to look at the social determinants of health that go along with this as well, right? Because if you're offering $50 million, I think that those of us in the community will take it all day. But I also think that you have to look at what is available in New Hanover County. And again, 50% of the people that work in the county don't live in the county, right? Because they can't afford to. So are we looking at socioeconomic factors? Are we looking at affordable housing? Are we looking at the other things in the community that are going to benefit? So are we saying we're giving $50 million to medical treatments, or are we giving $50 million to the other social determinants that are going to be essential in benefiting the people of New Hanover County, the people that we see and the people that we don't? Right? Because we're talking about equity. We're talking about the marginalized communities that if you handed somebody $50 million would not automatically get that.
I'll add one thing on that. Couldn't agree more. I do have a quote. Let's see if I can get it on my phone. Racism and all the other isms is legally constructed, socially maintained, politically expedient, and still confers too many economic benefits. So I think it's just something that I always think about in this work of how many other things are in limbo to make an impact, to get us to that number one health outcome ranking and these competing interests and priorities, right? And then there's a great book, Heather McGee. The book is called The Sum of Us, What Racism Costs Everyone and How We Can Prosper Together. Chapter 4, actually, I didn't realize this before I read it, but is right here in Wilmington. So definitely encourage you to check that out if not. But the book is incredible and really shows throughout history how our kind of social public goods were just taken away over this idea of race, and how we'd rather not have this amazing resort style pool here in the South because we don't want to use it together. And so instead of making that work and building community around it, there were dump trucks pulled up and dirt filled in, and now it just doesn't exist. And just thinking about that in one way of how our systems have just constantly competed against the greater good of everyone else.
This is a question, kind of a mix from me and an audience question. Our schools are also a really big first defense line when it comes to our children and making sure they're healthy, that they're receiving things that they need. And we talk about the fact that healthcare also happens outside of the clinical setting, right? So how do we ensure, in a way, is there any sort of curriculum that we can bring to our kids about healthy living? Things like don't smoke, things like this is what a healthy meal is supposed to look like, that they can bring back home to maybe, help teach the rest of their family.
I can talk on that. Coastal Horizons has a large hand in the community. We have Wilmington Health Access for Teens, which actually does medical services within the high schools of New Hanover County. I think that is one of the huge access points for education. If you have doctors, nurses, social workers within the school system, you are taking away one more barrier. If you want those doctors, nurses, health workers, whatever, to now educate people in classrooms, then you're breaking down that barrier even further, right? To say that you have a doctor or a therapist that you can access, even if it's one day a week, then it's there and you know it's there. If those therapists start doing education within the classrooms of this is what depression looks like or this is what addiction is, and it's part of that curriculum, then you're destigmatizing in general. And I think that that's huge. The more therapists, mental health workers behave, and I'm biased in this, right? But the more people that are willing to educate on mental health and break the stigma, the better. And if we educate our kids are going to, if not educate their parents, at least argue with them about the issues that are going on, and that's going to be huge in impacting later generations. You might not see the effects of therapists in schools, therapists and not just school psychologists, right? But therapists in schools for another generation, but that generation is going to understand how their mental health and how effective coping skills are impacting them and their kids and their families and the people that they're interacting with, and breaking down that generational trauma is essential.
And one of the things we have, and it's more along the lines of preventive and awareness, is that we really engage with the youth across the county and across New Hanover County, as well as the neighboring counties, to bring the youth and their families in a few times a year to look at all of the different disease states. And so we have an opportunity to create that awareness around, the healthy initiatives that you can take today that can make a difference over a lifetime. We also go out to the schools and participate in their health fairs and send that information home too. But any of the initiatives that we do at Novant Health, we oftentimes include anything that can go home and be shared with the youth and their families to help promote better connections to health and just at least bring it to top of mind. We talk about being number one. It's like anything else. It really becomes, if it's our target, if it's our focus, and that's where we all want to go, then we can get there, for sure.
Great. Well, that does it for our audience questions for this part of the panel. Thank you to our panelists. Thank you guys so much for being here. And thank you to all of you for taking time out of your lovely day outside to come and listen to us talk about health equity. Thank you again. Yeah.
We're going to take a break here. Next up is Fawn Rhodes. You're listening to The Newsroom. Stay with us. Listening to The Newsroom on WHQR. I'm Camille Mojica. Today we're hearing highlights from our Cape Fear conversation on health and social equity. In this segment, we'll hear from New Hanover County's Health and Human Services Equity Coordinator, Fawn Rhodes. I asked her about some things we weren't able to get to related to race and socioeconomic factors that contribute to health outcomes. She describes the situation in New Hanover as unique and not unique at the same time. Places all over the state that saw population booms have been racing to keep up with demand.
We didn't foresee the amount of people that were going to be coming here. Structurally, we didn't foresee the amount of people that would be here. So we're kind of in a catch-up space, trying to make adjustments for the amount of people and the population that we have here in our area. So what that really kind of looks like when we are talking about these issues is how can we play catch-up at the same time of putting into structural situations and implementing things at the same time. So we're building the plane and flying it at the same time, if that makes sense, right? And it's a challenge because we have so many people that are coming here and people's needs change on a regular basis. What we needed yesterday may not be what we need today. But at the same time, we've got to acknowledge what happened yesterday in order for us to fix what's today. Does that make sense? So that's what we're dealing with when we are talking about health equity in New Hanover County. That may be a a mixture of elements in terms of the answer, but it really is the truth. It really is complicated as far as how we are in our community because of that data and how we are looking. So we're doing everything that we can. We have a regional hospital that is in this area that is really helpful. We also have a health system, so Wilmington Health. And then we also have our leadership that is really doing as much as they can to help look at these things and what's happening in our area so we can be more progressive in getting things done.
So some of that data breaks also along racial lines.
It does.
Can you talk a little bit more about that?
So when we talk about racial lines, here in New Hanover County, our numbers, the last time I checked, we're approximately 13% when we are looking at our Black population. We're about 6% when we're looking at our Hispanic population, 3% when we're looking at our Asian population, 0.1%, if I'm not mistaken, when it comes to our Indigenous population. I kind of question that because we actually thrive or come from an indigenous community. So that's a little bit questionable. But anytime that you have a population or numbers like that, it's always going to be inequities and disparities in those smaller populations at higher rates than your larger majority population. That's just facts. That's just statistics. So what we're seeing in our community is not unlike what happens in any other smaller community when we are facing data such as that. Now, how do we impact that space? We have to be more intentional within that. Do we still have racial discrimination? Yes. Why? We have to ask those who continue to perpetuate that. That's not a question that we can answer for ourselves because we're the ones who are moving forward, trying to create relationships, trying to create trust, removing barriers and creating our policies and programs to structure it in a way that it is eliminating racial inequities in those spaces. But in terms of answering the question, it's a hard question to answer, but especially when you're not the one that's perpetuating that type of discrimination that people are experiencing. But what we can do is ensure that those gaps are removed. So, like I said, looking at your policies, your programs, the services that you have, make sure that you're putting in place things that can eliminate the opportunity for racial discrimination to happen. But at the same time, when those things happen, making sure that we address those things and being real and honest and confronting it, saying, yes, this did happen, and not being dismissive. And I think that's one of the things that New Hanover County has really moved in and embraced. We know what's happened in our past. We're very familiar with 1898. That's not something that we overlook. We have a variety of things that have happened in our community along with 1898. We had the Wilmington 10, right? And other situations that have happened here. But we have to acknowledge that, acknowledge the racial issues that have happened here, and then what can we do to work together to help eliminate those situations.
When talking about health equity, the word intentionality gets used a lot. The efforts need to be intentional. I asked Fawn how we can actually do that. How do we get down to that intentionality part, though, right? Because it does seem a little bit like a cultural thing to, let's say, have a developer say, well, I want my building to be accessible. Or to have somebody who's putting on, let's say, a community event say, well, I want this to be accessible to people. So, yeah, I do want to have someone who can speak ASL here, or I do want to have those noise-canceling headphones for people who may have sensory issues. It seems like a very cultural thing. How do we get to that intentionality part?
You know, a lot of times when we have these discussions, at the end of the day, it's really a behavior shift. It's how you think about it. It's just the fact that you even thought that I want to do something means that you're thinking about it. So the next step is you have to move forward. Don't let your thought become action. Equity is an action word when we have these conversations. It's not a theory. It's not an ideology. It's action. It's how do we put into place policies, programs, services, procedures, everything that's going to impact our community. That's the first thing. So if you're having the thought, then the next step you need to do is move out on it. Reach out to those people. Be proactive. Be intentional. Don't just go to Facebook and say, can you tell me the next service, right? Google is our friend. So utilize it. Reach out. Use your resources. Use your community. Have a conversation with a friend. Have a conversation with someone at work and say, hey, I'm doing a program and I want to make sure that I'm including X, Y, and Z. Can you give me some tips? You don't know who you don't know. You don't know what you don't know. So maybe they may have some tips that they can guide you. And they may say, I actually know someone who does this, that, and the other. Did you think about reaching out to them? Or could I make a suggestion? So that's how we move towards doing those things, is that if the thought comes through, then the next step is to put it into place. And if you don't know how to do it, it's okay. Reach out to someone and let them help you do that. We don't have to be subject matter experts on everything. That's the thing I think a lot of people become overwhelmed about, is that they think that they have to be the subject matter expert on every single situation. You don't. All you need to do is know somebody, or know how to get in touch with something. Be resourceful. And I think that we have gotten to a space in our lives where we're not resourceful. That if it's not in front of us, then we won't move out. And we have to stop waiting for it to show up in front of us, and we have to be the one to step out and be intentional. Whatever something, if it's a priority to you, you will get it done. That's something I've learned, and I tell my son all the time. If it's a priority for me, I'm going to make it happen. And we have to take that same attitude with every other issue that's important to us.
I asked her the same question I posed to our panelists earlier in the show. What would real transformational change look like in the field of health equity?
The real transformation change is a holistic approach. And that means it starts from the grassroots all the way to the top, to the roof. So grassroots is going to be a behavioral shift. So you have to, it really starts with, how do I think about things? An example I can give you was back in the 80s, and so you're too young for this, but before, back in the day, back in my day, there was not a 911 at all. So if you had to call for the police department, you just had to call 0. You dial 0, and then they would connect you to the police department or the fire department, right? And then 911 came into place. And once 911 came into place, it wasn't an immediate where people started calling 911, because they had to get used to calling 911. But over time, as they continue to talk about the messaging of, when you call 911, it's a one-stop shop. It not only does it connect you to your fire department, but it gets you connected to your police department. It gets you connected to emergency medical services. So it became habit. So now, whenever you hear 911 within the United States, you automatically know that I call this number if I need emergency services. That's the same thing when it comes to behavior shift. That was a behavior shift with our population, because those that came from the 50s and 60s, they didn't know anything about that, the 70s. So that is what I'm saying when it comes to a behavior shift. You have to do something consistently. That's one. You got to be consistent with the messaging that you're saying, repetitive. Everybody has to say the same thing on a regular basis. Everybody has to be doing the same thing. Everybody has to be working towards the same goal. That's when transformation happens, is when everybody is on the same page. We're all buying into the same point of view. We all want this thing, the end game, to happen. And then, so what are we doing to make that happen? So are we looking at, again, the policies that we have in place, your local policies, your state policies, your federal policies? Are they all mirroring each other, making sure that we're all lock in step with how we're doing certain things, right? The procedures. Are you making sure that everybody is following through with those procedures, no matter what the situation is, right? You're not giving a one particular pass saying, oh, because I want to do this, I'm a fast track you and I'm going to get you ahead of everybody else. You're following the procedures. Everybody's doing what they're supposed to be doing. Programs. Are we making sure that the programs that we're designing has the community's voice there? Stop designing programs and you have not included them at all. That's disrespectful. So design programs with them at the table, with their voice. It's not enough just to give people a seat at the table, but also let them be heard when they're at the table. And then don't dismiss the things that are being said. So as you're listening, so that's one thing. Practice active listening, and then put those things into place. And then the services that you're offering, are you making sure that those services are sustainable? That they have the capacity. That's a challenge that we have a lot of times, is that we start programs and we don't have the foresight to realize that there's not enough money to keep the funding going. So what are you doing to make sure that before this money runs out, that you've either secured another grant or you've gotten other funding coming into another space? Also, have you taught the people how to manage that money? If you're doing something at a local church, right? Do they know how to apply for a grant? Have you taught them how to apply for the grant? So when you leave, that they know how to take care of those things. But that money is there. Have you taught them how to do fiscal management and fiscal budget? Managing money for your house is not the same as managing money for a large organization. There's a lot more accountability within those spaces. A lot of things that we don't realize that has to take place. You can't wait till the last moment. New Hanover County is already doing their budget right now. We're in budget season and we're talking about that, right? And that budget is going to be for next year. But truth be told, they already have a budget for the next 4 or 5 years. You can't wait to the last moment. So those are ways that transformational change happens, is that when it all comes together, you're all in the same place. Everybody's on the same page in what it is. And don't try to tackle everything at one time. I think that we realize that there is so many inequities and disparities within our community. But like I told my son, pick a struggle. So pick one and work on that. And as we work on that, then we can have capacity start moving forward to work on something else. Or if you're not in the space to be able to handle that, let those who do know how to handle it, let them be the one. We don't always have to be the one to manage and take care of everything. Sometimes the county is not the best space or the best place for something to sit. Maybe it might be a community partner that has been doing that work for a whole lot longer than we have and that has the insight. A great example I can give that is the YWCA. They have a great handle on how to move out on women's issues and how to tackle various things, right? And so when it comes to certain things, let those things house at those areas. The food bank, Good Shepherd. Good Shepherd has their pulse when it comes to our homeless community and our shelterless community. So let those people that champion that space be the owners of that space. And we support and help them in ways that we can support and help them. But what happens is that sometimes we take off more than we can chew, and we end up housing programs in the space that may not be the place to house it.
We're going to take a quick break here. Next segment, we'll hear more from Fawn Rhodes. Stay with us. You're listening to The Newsroom on WHQR. I'm Camille Mojica. On today's show, we're hearing highlights from our Cape Fear conversation on health and social equity. In this segment, we're hearing more from Fawn Rhodes at New Hanover's Department of Health and Human Services. One of the main barriers to accessing healthcare in our region involves transportation and free time to actually attend doctor's appointments. So I asked Fawn a very simple question. How much of health inequity seems to be a socioeconomic issue?
All of it is a socioeconomic issue, social determinants of health. And actually, to be honest with you, it's not just social determinants of health. One of my favorite books that I encourage people to get a hold of and read from front to back and read it front to back again is by Dr. Daniel Dawes, and it's The Political Determinants of Health. They go hand in hand. Policy determines the level of or the types of social opportunities, socioeconomic opportunities that we have. So when we, an example of this is we're going to dial back time. We're going to go back to time again, Cammie. I'm sorry.
That's okay.
But we're going to go back in history, and we're going to talk about redlining, okay? And so back in those, when redlining came, that was strategic policies that were put into place that prevented racially ethnic communities from living in certain places, from purchasing homes from having types of insurance, from the types of mortgages that they could receive. That was political. That was policy that dictated that, which impacted what? Your social determinant of health. It impacted where you could live. It impacted what you could afford. It impacted what type of job you could have. So they go hand in hand. The political determinants of health and the socioeconomic determinants of health all work together with each other. So we have to be mindful of when we think about how things move. You can't just impact your social determinants of health without impacting your political determinants of health.
I think one of the interesting sound bites conversations that came from the panel was Dr. Amar Bowers with MedNorth, with Dawson Med, basically said your zip code is a greater determinant of what type of care and you'll receive in your health outcomes than sometimes the color of your skin is. It's your zip code, which kind of blew me away a little bit because I didn't think about it that way. But that was kind of what I wanted to get to the core of, was how much of it is it the color of your skin, or is it what socioeconomic background you come from or fall into? Is it where you live? Is it, your family history and things like lack of trust in institutions such as the medical institution, right? Where exactly does the health inequity come from? Is it from one place? Is it from a whole bunch of different places? I think it's just a very big scope of an issue that we're trying to kind of get to the bottom of to see how you can even begin to move the needle.
And you're right. Two things can be true at the same time. It's a soup of issues. That's that when you taste your soup, you don't just taste the celery. You taste the celery, the onions, the garlic, and everything that's in it. And the issues that we encounter when it comes to health equity, it's all things included. For some it may be racial issues. For some it could be economic issues. Some it could be neighborhood issues. It could be educational issues, right? And for some it could be both. So it's not a one answer to it. And unfortunately, it's not one of those things like a medicine situation. Like when we think about polio, the way that they were able to fix it was they were able to go into a lab and put all these different chemicals together. I don't want to say chemicals, excuse me, but they were able to put all these different things together. And now they have found a medicine and a cure for polio. Boom. That is not the situation when it comes to health equity. To the end of time, we're going to have health inequities because somebody, somewhere, somehow is going to experience something, whether it's going to be from a disability situation or whether it's going to be from an ethnic situation. Racial issues are never going to end. Unfortunately, it's life, it's people, it's what we're dealing with. And as long as we're dealing with humanity, we're going to have some type of health inequity. But what we can do is put in programs, policies, and I know I sound repetitive when I say this, but I'm very serious. What we can do is put into place policies, programs, procedures, and services and ensure that those things that we're doing are doing them from as much of an equitable lens that we can, so we can eliminate those gaps, so it mitigates the opportunity of people experiencing health inequities and health disparities. When we talk about Black maternal health, those issues, those women, those issues are preventative. 80% of Black maternal health disparities are preventative. So we're talking about things, real things that can be put into place. These are not situations or always things attributed to the patient themselves. Right? A lot of times when we talk about health issues, we always want to place the ownership on the person. It's not always on the person that's dealing with these issues. It is actual structural and systemic things that we can actually look at and we can say, we can do better. Quality assurance is not always about saying that what you're doing is bad. It's saying that how can we improve something. That's one of the wonderful things about our strategy department, that we don't look at it from what you're doing wrong. We're looking at, you know what, you're doing a great job right now, but how can we come in and help that be better? And that's what we have to also take a look at. Not everything is negative. If I point something out to you, I'm not coming at you from a negative perspective. I'm looking at how can I make you be a better person, or how can I improve what you're doing, right? And so I think some of that is that we have to lower our defenses, and when we're communicating with one another, and we can't always go in with Mike Tyson punch out, and thinking that everybody else is coming against us. It's not the case. Sometimes someone else may be better at something, and they see it from a different perspective. And the way that you build relationship is that you build trust. But you can't have trust if I don't have relationship. And I can't have trust if I don't know your story. We have to sit down and have conversations. And we need to share our stories and know that everyone's story is valid. Everyone's story. Everyone has one. We all have biases. I was raised Seventh-day Adventist. I tell this story all the time about how I was in private school all the way up to 6th grade. And Seventh-day Adventist is a Christian denomination. We just go to church on Saturdays. That's the difference, right? And so for the longest time, all the way up from the 6th grade, I was in Seventh-day Adventist Christian school. And when I went to school and I learned that people went to church on Sunday, I thought that they were the aliens. I was like, what? What is going on?
Yeah.
Everybody in my family goes to church on Saturday. And I was also raised vegetarian. And so from all the way up until 13 years old, I was vegetarian and didn't know that other people were eating anything other than that. And so when I went to school and I started realizing that people eat other stuff, I was that child like, oh my gosh, you're eating the cow? No. I was the one that got on people's nerves, no, you killed the goldie bird, the goldfish, that type of thing. But I say that to say we all are raised with biases, good, bad, or indifferent. That doesn't make us any less or worse because we have our own experience in life. Some people are from the North, some people are from the South, right? But we have to respect their story and we have to respect their differences and say that they are entitled to that. That's their life story. That's what they experienced. Now, what can we do to have a meeting of the minds? Maybe it's not having that racial discussion because there's some trauma that's in that space, right? Maybe it's not having that and starting off with that discussion is what I'm saying. But eventually we will get there. But let's start at another place that we all can be, have a meeting of the minds, right? Everybody remembers being in school. School is a great equalizer. Or everyone remembers going to a concert or a specific meal or something like that. Find something that's your equalizer that you can have a conversation about. Let that be the beginning of your story, where you start. And then as you begin that story and you develop relationship, now you can have those harder conversations, racial issues, LGBT issues, people with disability issues, those things that may be a little bit more challenging for others. For me, it's easy because this is my work and this is my passion. I like to say God found a way to take my pain and turn it into my purpose and make it my passion. So for others, that may not be so, but you got to meet them where they are and you got to find what's important to them. And if you find what's important to them, that's when you're going to start finding ways to remove the inequities and the disparities.
All right, well, that's all the time we have for this episode of The Newsroom. Thank you to our panelists, Jason Black, Dr. Umar Bowers, Haley Sink, Kevin Briggs, and Lee Quarles. And thank you to Fawn Rhodes. Thanks also to WHQR's Ken Campbell for technical assistance. If you missed any part of the show, you can find it at WHQR.org or wherever you get your podcasts. If you've got questions, comments, or an idea for a future show, email us at newsroom@WHQR.org. I'm Camille Mojica. Thanks for listening, and I hope you'll join us for the next episode of The Newsroom.